большое. Спасибо. Если они еще не ушли никуда. Спасибо. Good day. Our lecture today is colorectal cancer. Excuse me, we late because we have one problem with the translation. Excuse me. Colorectal cancer or cancer of large intestine is the term which unites two groups of tumors, colon cancer and rectum cancer. Colon cancer include cecum ascending colon, transverse colon, descending colon, and sigmoid colon. Rectum cancer divided into two subgroups, cancer of the anal canal of rectum and recta sigmoid cancer and ample of the rectum. Epidemiology. Colorectal cancer is the third most common malignant tumor after breast and lung cancer in women and prostate and lung cancer in men. Incidence high rates is in USA, Canada, Scotland, lowest rate in Japan, Africa, and Asia. Less than 4% from 100,000 population. The incidence is decreased the last years. Death rate in male, the death rates are highest in Denmark, behind to be 38.5%. In female, the death rates are highest in New Zealand, 26.9%. In Southeast Asia, the death rates are 22.7% in male and 20.2% from 100,000 population in female. The lowest death rates in male are noted in Peru, less than 3%. In female, the lowest death rates are estimated in Peru, less than 3% per 100,000 population. Up to age 50 years, the incidence of colorectal cancer is similar among men and women. However, after age 50 years, men have higher incidence rate than women. Males and females are affected by bowel only equally. The male to female ratio for colon cancer is about 1 to 1. But the male to female ratio for rectal cancer is 1.4 to 1. Age. Mean age of rectal cancer incidence is 62 years. Incidence rates begin to increase substantially during the sixth decade of life and continue to increase thereafter. Mechanisms producing colon cancer. There are three basic pathogenic reasons of development of colorectal cancer. The action of carcinogens in food proliferate processes in intestine mucosa and dysbacteriosis. Dalo. Ну хорошо, подождите, пожалуйста, может, минут. Да, извините. Хорошо, я найду, да. Ну, извините, я просто сейчас чуть-чуть еще. Хорошо? Да, спасибо. Mechanisms producing colon cancer. No known mechanisms account for the causes of cancer in the proximal. We told terminology proximal colon, it means the right side of colon, including cecum and ascendens part of colon and liver uh, junction of colon. We told right side or proximal side. Cancer of the distal side, it means left side colon and the sigmoid junction seems to be associated with the type and amount of fat consumed. The left side, including sigmoid colon, descendants part of colon, and spleen angle part of colon. Mechanisms producing rectal cancer. There is some parallelism between the occurrence of rectal cancer and distal colon cancer. A weak association possibly due to promoting element like bile acid. Some epidemiological studies have associated the intake of alcoholic beverage to rectal cancer. Risk factors. Age after 50 years, familial polyposis coli, Gardner's syndrome, Peter-Jeghers syndrome, family cancer syndrome. Non-hereditary acquired disease like colon polyps, chronic ulcerative colitis, and Crohn's disease. Lack of vitamins A, C, and E, and dense vegetative fibers in the diet. Asbestosis workers, show workers, and machinists. Particularly this risk for anal form of cancer. The last, asbestos workers, show workers, and machinists. More sufficiently, precanceriosis disease of bowel are family polyposis of intestine, Gardner's disease, non-specific ulcerative colitis, Crohn's disease. Familial cancer syndrome. The precancerous disease of rectum are family polyposis of intestine, Gardner's disease, various polyps. The polyps had three subtypes: widely polyps, polyps, thick polyps, and virus polyps. Non-specific ulcerative proctosigmoiditis. The pathologic evolution. In comparison with other malignant tumors, large intestine cancer is characterized by some biological features. Fifth, slower growth. Unlike other types of malignant tumors, for example, lung cancer or liver cancer, unlike the colorectal cancer, is had slower growth. Yes, we can told that the patient had period complication from the tumor as obstruction of intestinal than any metastasis. Unlike in lung cancer, the patient had metastasis, distant metastasis, than any complication before. Later, metastatic spread. Later spread into the adjacent organs. More frequent development of inflammatory complications. Histopathology of colorectal cancer. About 90% are present as adenocarcinomas, malignant carcinoid, sarcomas, and lymphomas. In the anal canal, there are several different cell types with different biological behaviors, including squamous cell carcinomas and cloacogenic carcinomas. Anal form of adenocarcinomas are rare. Site: 45% of cases occur distally part in left colon, it's the most common, as we told, sigmoid part of colon, descendants part, and spleen angle. 40% in proximally in right colon, cecum, ascendens, and liver angle. 15% only present in transverse colon. Metastatic spread. Metastatic spread of large intestine cancer may occur consequently in following lymphatic collectors. Epiploic nodes in subperitoneum layer of bowel wall. Paracolic mesenteric lymph nodes. Intermediate nodes near the left intestinal artery. Principal nodes of mesenteric bases. Metastatic spread. Usually in large bowel, right side and left side spread to liver and lung. But in low rectal and anal cancers tend to spread laterally to perianal nodes and may appear in inguinal nodes rather than in retroperitoneal nodes. Why? Because from the blood supplying of the lower part of rectum and anal canal. TNM classification of colorectal cancer. Stage grouping for colon cancer. For colon cancer and for rectal and anal canal, it is different staging group. The stage 0 is the tumor in situ, N0, M0, no lymph nodes evidence and no distant metastasis evidence. The stage 1, T1 in 0, M0. T1, the tumor invasive submucosal layer. Stage 2, it is T3 in 0, M0. T3 to serosal layer, invasive, or T4 in 0, M0, invasive to serosal layer. But no evidence lymph node metastasis and no evidence distant metastasis. Stage 3, any T in 1 lymph node metastasis and no distant metastasis. Any T in 2 M0. The stage 4, any T, any N, M1. There are distant metastasis. For rectal anal canal cancer, the stage 0 is tumor in C2 in 0 in 0. The stage 1, T1 in 0 in 0. 2, the same T2 in 0 in 0. And 3 stage which divided to 2 groups. Stage 3A and stage 3B. Stage 3A, when the tumor size or tumor from 1 to 3 or T4 in 0 in 0 or from 1 to 3 tumor but in 1 lymph node metastasis. 3B, the T4 in 1 M0 or any T in 1 to 2 M0. Stage 4, any T, any N, but there are distant metastases. Clinical manifestations of colon cancer is divided into the period of latent current, the period of intestinal disturbance, and the period of general disturbance. The main clinical forms are obstructive form with intoxication and anal toxianemic form, dyspeptic form, pseudo-inflammatory form, intracolytic forms. But the pathognomonic signs of colorectal cancer are not present. Cancer symptoms. Iron deficiency anemia is often sign of the disease in right side of colon. Uh, the complication from cancer tumor, which localized in right side of colon, the first complication will be anemia before obstruction. But in left side, the first complication will be obstruction, then anemia. The most common symptom of cancer in ampulla of rectum is the stool with blood and mucous discharge. As we told before, there are general symptoms and there are special symptoms for every localization alone. Predominating symptoms of cancer in anal part of rectum are severe pain during the defecation and tenesmus. Physical examination. The plan of objective examination of persons aged 40 years and older with complaints for intestinal pains and constipation should include palpation of the lymph nodes in inguinal areas, digital rectum examination, gynecological examination in women. Rectum cancer, in digital examination, there are the seizure, polyp with ulceration, big ulcer with hard border, hard ring which does not pass a finger. Diagnostic colorectal cancer. Second method of diagnostics is X-ray examination. Barium studies with or without eye contrast may be very helpful in establishing the diagnosis. As here we see two localization of tumor. Colonoscopy method of diagnostics is helpful in evaluating the level of the tumor, the clinical signs of malignant degeneration of rectum polyps are appearance of the sessile polyp with ulceration. Other additional methods: cystoscopy, if we suspicion if there are invasive to urine bladder, and intravenous pyrography studies are rarely indicated except for very large tumors of the rectum. Chest X-ray or chest CT scan is necessary only for pre-anesthetic evaluation to exclude distant metastasis or include distant metastasis. Liver CT scan are rarely indicated except for cases where the clinical seeks to confirm clinical judgment of medical inoperability. Other additional methods: laboratory tests should include a carcina embryonic antigen, CAA, the elevated of carcina embryonic antigen level preoperatively suggests metastatic disease. Post-operative CAA should be obtained 1 or 2 months after surgery. A normal level is favorable sign. Elevated of CAA strongly suggests acute residual disease. Differential diagnostics. If the older patient has blood and mucus in stool, it is necessary to make differential diagnosis either of colorectal cancer or hemorrhoid or dysentery. Cancer of cecum and ascending colon must be differentiated from appendicular infiltrate, anemia of the other reasons, tumor of the right kidney, retroperitoneal tumors, tuba ovarian cyst or ovarian carcinoma in women. Cancer of the anal part of rectum must be differentiated from hemorrhoids and benign polyps. Principles of treatment. Primary tumors should be removed surgically. Quality of life is improved even in the presence of distant metastasis. Pre or post-operative radiation therapy is beneficial in preventing local recurrences and rectal carcinoma. The exact role of radiation plus chemotherapy as an adjuvant for rectal cancer is undergoing intensive clinical trials, but it appears very promising. Chemotherapy also may help improve the survival when given as an adjuvant therapy in colon cancer. Surgical treatment. Polyps should be evaluated with colonoscopy. Pedunculated removable polyps should be resected. Malignant polyps with no evidence of stalk involvement and clean line of resection require no additional therapy. If there is submucosal involvement or if the resection line is involved, then the risks of residual or recurrent disease are unacceptably high and further resection is indicated. Surgery is the primary treatment with resection of the segment of the involved intestine. Localization, cecum, or liver angle, or middle part or ascending colon, we must do right side hemicolectomy. In transverse colon, we do resection of the transversus with lymph dissection. Left part descending colon. Spleen angle, we do left side hemicolectomy. In sigmoid, we do resection of sigmoid. In colon cancer, if it is a rectosigmoid cancer, we do intra-abdominal resection of rectum, or if it is the lower part of rectum, we do extirpation of rectum. For radical surgical treatment of cancer of ascending or descending part, the operation hemicolectomy with intra-abdominal anastomosis is performed with lymph dissection. In sigmoidal and high rectal lesions, bowel resection with intra-abdominal anastomosis may be impossible. In these cases, it is necessary to make Gartmann's operation. What means Gartmann's operation? Gartmann's operation is the radical surgery with formation of artificial anus in proximal segment of colon after cancer removal. The name is Gartmann's operation. Hartmann's operation. Laparoscopic colectomy is a minimally invasive new technique. The procedure consists of mobilizing the colon laparoscopically and performing an extracorporeal anastomosis. In some situations, especially in the lower sigmoid colon, an intracorporeal anastomosis can be performed. In low rectal lesions and abdominal perianal resection may be necessary. Abdominal resection, perianal resection of rectum in low rectal cancer, or extirpation. Local excision of rectal cancer helps to avoid colostomy for well-differentiated lesions less than 3 cm in size. Radiation therapy. Patients whose tumor lie within 15 centimeters of the anal verge and go through the bowel wall or involve regional lymph nodes are benefited by post-operative adjuvant radiation therapy. Pre-operative therapy use would also involve treating many patients unnecessarily. Chemotherapy is carried out after radical surgery in case of metastatic spread into regional lymph nodes, stage 2 to stage 3. Anal cancer seems to respond well to radiation and 5-fluorouracil plus metamycin chemotherapy. The over 5 years survival for colorectal cancer is 52%. However, when the disease is diagnosed in localized stage, survival is 84%, up to 84%. So survival rates for colon cancer is 54 years in recent years. Rectal cancer survival rates is 37 to 52%. Thank you very much.